Welcome to the Funnel Effect. Today's deep dive is based on a really foundational piece of medical research. It's something that definitely requires our full attention. The comprehensive review article, Peripartum Cardiomyopathy. It's authored by Zoltan Arani, MD, PhD, and it was expertly edited by Jane A. Leopold, MD. You'll find it published in the New England Journal of Medicine, Volume 390, Issue 2, dated January 11th, 2024. Okay, let's unpack this. We are diving into a condition that is just devastating, really, precisely because of when it strikes. We're talking about peripartum cardiomyopathy, or PPCM. It's a form of acute and sometimes really severe cardiac degeneration, and it targets women at one of the most critical times of their lives. That transition into motherhood. It's like a sudden crisis of the maternal heart muscle. And, we're only now starting to truly understand it at a molecular level.
Yeah, and understanding PPCM, it really starts with having a sharp clinical definition because it's often mistaken for other issues, especially, given the timing. PPCM is generally defined as maternal heart failure accompanied by systolic dysfunction.
Okay, systolic dysfunction, meaning the main pumping action of the heart is weakened.
Exactly. The heart's primary pumping ability is severely impaired. Specifically, we look for a left ventricular ejection fraction, or LVEF, of less than 45%. And crucially, this dysfunction has to develop either in the last month of pregnancy or within the first 5 months after delivery. And importantly, it's defined only when there is no known pre-existing structural or functional heart disease.
Ah, right. So if a woman already had, say, a known valve problem or something from a previous heart attack, that wouldn't be PPCM. This is completely new, a new onset of heart failure triggered specifically by the peripartum experience itself.
Precisely. It's the sudden and previously unexplained nature of the cardiac failure during this specific time window that defines it as PPCM. And while the definition gives those strict boundaries last month of pregnancy to 5 months postpartum, the source does note that, sometimes cases can present slightly outside that range, but the timing is always the critical factor.
So, our mission today is to take this really complex, high-stakes medical issue and basically extract the vital knowledge for you. We'll start by mapping out the global prevalence and, importantly, the profound disparities we see. That's quite shocking, actually. Then we'll tackle the challenge of diagnosis. It's often delayed because, as you mentioned, the symptoms can mimic normal pregnancy. And finally, we'll dive deep into the vascular hormonal model of its cause, that's fascinating stuff, and explore the crucial uncertainties around current management and what needs to happen next in research.
Okay, so to start, we really have to look at the global scope of PPCM. And the numbers themselves, they're highly variable. And the variability immediately gives us clues about what might be driving this disease. Globally, PPCM complicates roughly 1 in 2,000 births.
1 in 2,000. Okay, so that already makes it significant, even if it's relatively rare compared to, say, gestational diabetes.
Right. But that 1 in 2,000 figure, it's just an average. And it hides these massive peaks of risk in certain areas. The regional variation is where the story truly becomes urgent.
Right, I remember seeing those numbers. They're pretty stark.
Absolutely. The variation is staggering.
Yeah.
And it strongly suggests that local factors, things like socioeconomic status, maybe diet, access to healthcare, or perhaps even undiscovered environmental triggers, are hugely influential. For instance, in places like Haiti, the incidence rate jumps dramatically. We're talking 1 in 300 births.
Wow, from 1 in 2,000 to 1 in 300.
Exactly. And then in parts of Nigeria, the risk becomes enormous, 1 in every 100 births.
1 in 100, that's incredibly high.
It is. When you compare that to the global average of 1 in 2,000, seeing rates 20 times higher forces us to think beyond just simple biology. We have to consider systemic causes.
And this level of risk, it translates directly into a crisis of maternal mortality, doesn't it? This isn't just a chronic condition people live with. It can be acutely fatal.
That is the tragic reality, yes. Yeah. PPCM is now recognized as a leading cause of maternal death in many parts of the U.S. and, indeed, globally. To put that into a clinical context, PPCM is responsible for approximately 60% of all cases of cardiogenic shock that occur during pregnancy or in that early postpartum period.
60% of cardiogenic shock. So that's when the heart acutely fails to pump enough blood for the body's needs.
Correct. It's an absolute emergency. And even for those women who survive that acute phase, recovery is often a complex long-term process. Some may require advanced measures like left ventricular assist devices, LVADs, or even in some cases, cardiac transplantation.
So as we try to understand who is most susceptible, the source draws some strong connections between PPCM and other common issues during pregnancy. What are the strongest risk factors they've identified?
Yeah, there's a definite pattern emerging. It strongly links PPCM to hypertensive disorders of pregnancy. About one-third to one-half of all PPCM cases are connected to conditions like preeclampsia.
Okay, that link to preeclampsia seems really important.
It's a crucial epidemiological link, yes. And it kind of foreshadows our later discussion on the hormonal pathways involved, as we'll see. Beyond hypertension, other strong risk factors include multiple gestations, so carrying twins or triplets, advanced maternal age, and also anemia.
And just to be clear, because this often comes up, what about the mode of delivery? Does a C-section increase the risk?
That's a great point to clarify. The source is quite clear. The mode of delivery, whether it's vaginal or a C-section, is not recognized as a risk factor for PPCM.
Okay. So that reinforces the idea that the trigger is more systemic, more physiological, rather than something mechanical or surgical related to the delivery itself.
That's right. The risk seems intrinsic to the physiological state of late pregnancy and that early postpartum recovery phase.
Now, let's bring it specifically to the United States, because the data there reveal these profound racial and geographic inequities that are just central to understanding the disease's impact.
Yes, the disparities in the U.S. are stark
Yeah.
and deeply concerning.
The article states PPCM is 4 times as likely to develop in Black women compared to white women in the U.S. 4 times. That's an enormous difference in incidence alone.
It is a shocking disparity. And critically, it doesn't stop at incidence. It extends well beyond just getting the disease. It deeply impacts survival and long-term recovery. And that really points towards major issues within healthcare delivery and, the social determinants of health.
So it's not just getting the disease, it's also about surviving it and recovering from it.
Exactly. Mortality rates overall hover around 20%, which is already high. But they are highest among Black women in the U.S. and also among women in less developed countries worldwide.
Let's focus on that long-term outcome disparity detail because it really highlights the lasting damage. The source says Black women in the U.S. are twice as likely as white women to have persistently impaired heart function a year or more later.
That's correct. Twice as likely to have ongoing heart problems.
And even for those Black women who do recover their heart function, the article notes it takes them twice as long to get there compared to white women.
Yes. Double the time to recovery.
This isn't some subtle statistical difference. This is a radical difference in prognosis based on race in the U.S.
It's a devastating insight, and it demands explanation. The source material suggests that while, yes, genetic factors might play some minor role, this massive disparity is likely driven primarily by social and systemic factors. It specifically cites things like neighborhood deprivation, lack of resources, environmental stressors, and also potential provider bias, contributing to delayed diagnosis and perhaps substandard follow-up care.
So the system itself might be failing these women at multiple points.
That's what the evidence points towards. If you have a community facing a 4-fold higher risk of developing the disease and a 2-fold lower rate of functional recovery, well then addressing the underlying systemic drivers becomes just as urgent, if not more so, than pursuing the molecular causes in the lab.
Okay, so given this high mortality rate, the severe risk of complications like shock or clots, you'd really hope for a fast, straightforward diagnosis. But PPCM sounds like the ultimate diagnostic trap. Its symptoms are so effectively masked by what's considered normal in late pregnancy.
That really is the central challenge here. The classic symptoms we associate with heart failure, like dyspnea, which is shortness of breath, orthopnea, that feeling where you need to sit up to breathe comfortably, swelling or edema, particularly in the legs, and maybe elevated jugular venous pressure.
Things that would scream heart failure in another context.
Exactly. But in late pregnancy, those very symptoms are often just considered part of the expected discomfort of the 3rd trimester.
Right. Who doesn't have swollen feet or feel breathless climbing stairs when they're 9 months pregnant?
Precisely. It's this perfect, almost cruel convergence of normal physiological changes and potentially catastrophic disease onset. The patient herself, and sometimes even the clinician, might normalize symptoms that, outside of the context of pregnancy, would trigger an immediate cardiology referral.
So it really requires a doctor to have a very high index of suspicion, to think, could this be more than just pregnancy?
A very high index of suspicion is crucial, yes, especially when symptoms seem excessive or if they're worsening rapidly. Because the consequence of a delayed diagnosis is often that the woman presents already in crisis. The presentation can be accelerated and catastrophic, including, as we mentioned, cardiogenic shock or life-threatening arrhythmias or dangerous thromboembolic events like blood clots traveling to the lungs or brain.
And then there's the timing puzzle. You mentioned this offers another clue and links back to the hormonal causes we'll get to. When does PPCM actually tend to show up?
The timing is quite specific and very revealing. The vast majority of cases, somewhere between 60 to 90%, occur after delivery.
After the baby is born, not during the peak stress of labor.
Mostly after, yes. And the highest incidence, the peak risk period, is concentrated in that very first postpartum week.
Wow. That's often the time when the mother has just been discharged from the hospital, right? The constant medical monitoring ends, and she's transitioning into the intense demands of caring for a newborn at home.
Exactly. It's a particularly vulnerable period.
And we saw earlier how this timing can link directly to disparity. The source highlighted that in the U.S., Black women are more likely than white women to present later in that postpartum period.
That's right. And that later presentation tragically correlates with poorer outcomes. They might be waiting longer to seek care, perhaps due to lack of support or resources, or maybe their initial symptoms were dismissed or downplayed.
So that delay is a major factor in the worst prognosis. Okay, so because the presentation is so subtle and often masked, you said PPCM is fundamentally a diagnosis of exclusion.
Yes, that's the standard approach. The first step is always ruling out all the other conditions that could potentially cause sudden heart failure in a young, otherwise healthy woman around the time of childbirth.
So it's a process of elimination, a rigorous one, it sounds like. What are the key things, the key differentials that doctors need to rule out first?
Well, they have to systematically exclude quite a variety of conditions. First, obviously, any pre-existing structural heart disease needs to be ruled out, usually using the patient's history or any previous heart imaging they might have had. Then, it's crucial to distinguish PPCM from something like preeclampsia-induced pulmonary edema. Preeclampsia itself can cause fluid to back up in the lungs, making breathing difficult.
But that's not the same as the heart muscle itself failing to pump, right?
Correct. PPCM requires that severe systolic dysfunction, the LVEF, below 45%. That impaired pumping is typically absent in cases where pulmonary edema is linked only to preeclampsia without underlying cardiomyopathy. Furthermore, clinicians must exclude other acute catastrophic events, things like a pulmonary embolism, a blood clot traveling to the lungs, or spontaneous coronary artery dissection, SCAD, which is a tear in the heart's arteries, more common in younger women. Even rarer causes, perhaps chemotherapy-induced cardiomyopathy from a prior cancer treatment, need to be considered and ruled out before landing on the PPCM diagnosis.
Okay, so once all these other possibilities are confidently ruled out, what diagnostic tools actually confirm the signature dysfunction of PPCM?
The absolute cornerstone is echocardiography.
An ultrasound of the heart.
Exactly. This non-invasive imaging technique is essential. It's used to document the defining feature, that LVEF below 45%, confirming the impaired pumping function. And it also helps to exclude other structural abnormalities like valve problems or congenital issues that might point towards a different diagnosis.
What about blood tests? Are there specific biomarkers?
Beyond imaging, we do look at biomarkers. Now, currently, there isn't one single definitive diagnostic biomarker for PPCM. However, plasma brain natriuretic peptide levels, or BNP levels, are typically significantly elevated in patients with PPCM.
And BNP is a marker of heart strain or stretch.
Yes. And importantly, BNP levels don't usually change substantially during a normal, healthy pregnancy. So if you see a high BNP reading in a peripartum woman with symptoms, that should immediately raise the suspicion for heart failure and prompt the necessary imaging, like the echocardiogram.
That sounds like a potentially useful screening tool, especially in settings without immediate access to echo.
It is. And the push to use BNP more widely, particularly in non-specialty centers or emergency departments, is seen as a key strategy. It could help reduce those dangerous diagnostic delays and maybe start to address some of the observed racial disparities in timely diagnosis.
And finally, the source strongly suggests that genetic testing should be considered, often as part of the initial workup. Why is that, if the onset seems primarily hormonal or environmental?
That's a great question. It's because PPCM is increasingly viewed not just as a hormonal problem, but as a disease where a specific environmental or hormonal trigger meets an underlying genetic predisposition. Genetic testing helps identify those women who might be carrying variants associated with other forms of non-ischemic dilated cardiomyopathy, or DCM.
So it suggests PPCM and DCM might be related, maybe on a spectrum.
Exactly. They appear to share some underlying molecular vulnerabilities. And finding these variants isn't just about confirming the PPCM diagnosis itself. It provides crucial information for long-term management, for monitoring the patient, and importantly for family counseling regarding potential risks in relatives. Okay, this section I think represents one of the most exciting breakthroughs in cardiology recently, really understanding the fundamental cause of PPCM. The new model completely shifts us away from some of the older theories.
Like the idea that the heart just couldn't handle the extra workload of pregnancy.
Right. That old thinking, it makes sense on the surface, doesn't it? Pregnancy is a physiological stress test. You've got increased blood volume, increased cardiac output.
But as we established earlier, the timing is all wrong for that explanation.
That's the key point. The disorder is temporally discordant with the peak hemodynamic stress. That peak load on the heart actually occurs much earlier in gestation, usually mid-pregnancy. PPCM hits later. Furthermore, other early theories centered on inflammation, the idea of myocarditis, maybe a viral attack on the heart muscle. Those have also been largely discredited.
How so?
Well, when researchers looked at biopsy specimens from women with PPCM, they rarely found evidence of viral genomes. And cardiac MRI scans typically lack the characteristic patterns of scar tissue or inflammation that you'd expect to see with myocarditis.
Okay, so if it's not primarily an inflammation issue and it's not simply the heart being overloaded, what is the new answer? What's causing this?
The new understanding is that PPCM is fundamentally a vasculohormonal disorder.
Vasculohormonal, meaning blood vessels and hormones.
Precisely. It seems to be a specific kind of crisis triggered by certain pituitary and placental hormones interacting with an intrinsically susceptible heart muscle, particularly affecting the heart's own blood supply. We now have two main hormonal culprits identified that appear to work together, unfortunately, to damage the inner lining of the heart's small vessels, the endothelium.
Okay, let's break those down. Tell us about the first major player, the hormone we usually associate with lactation.
That would be prolactin. Prolactin is secreted by the pituitary gland, and its levels naturally peak during lactation to stimulate milk production. But crucially, in women who develop PPCM, something goes wrong with how prolactin is processed. It gets cleaved, basically, broken down into a smaller, abnormal fragment. It's a 16 kilodalton or 16 kilodiop breakdown product. And this smaller fragment, this 16 kilodiop prolactin, turns out to be highly toxic, specifically to the heart's blood vessels. It's classified as a potent vasoinhibin.
Vasoinhibin, so it actively inhibits or damages blood vessels. It sort of chokes off the blood supply within the heart muscle itself.
That's a good way to think about it. It acts directly on the delicate cardiac vasculature, damaging those crucial endothelial cells, the cells lining the inside of the tiny blood vessels. And this damage then triggers the systolic dysfunction, the heart failure, through a couple of mechanisms. First, it can cause direct cardiac ischemia, a lack of local blood flow, and oxygen getting to the heart muscle cells themselves.
Okay, so direct damage from lack of oxygen.
Right. And second, and this is a really elegant piece of biology they've uncovered, it triggers what's called paracrine signaling. The damaged endothelial cells start secreting these tiny vesicles called exosomes.
Exosomes, like tiny little communication packages sent from one cell type to another.
Exactly like that. And these specific exosomes, released by the damaged endothelial cells, contain a particular microRNA. It's called microRNA 146A. Now, microRNAs are small molecules that regulate gene expression. They tell genes whether to switch on or off. When the heart muscle cells, the cardiomyocytes, absorb these exosomes coming from the damaged endothelium, they essentially receive these miscoded instructions. And this specific microRNA 146A promotes cardiomyocyte apoptosis.
Apoptosis, programmed cell death.
Correct.
So let me see if I've got this. The toxic prolactin fragment damages the heart's blood vessel lining. Those damaged lining cells then send out these little packages carrying microRNA 146A, and when the heart muscle cells receive that message, it basically tells them to self-destruct.
That analogy captures the destructive pathway perfectly. It's a cascade of damage initiated by that abnormal prolactin fragment.
Which explains why suppressing prolactin itself is such a logical therapeutic target, which we'll get to later.
Absolutely. Now, let's talk about the second major hormonal pathway. And this one connects the dots back to preeclampsia and those hypertensive disorders we discussed.
Okay, bring back the placenta and that link to high blood pressure in pregnancy.
Right. So the placenta, especially in late gestation, secretes large amounts of a molecule called soluble FMS, like tyrosine kinase 1. We usually just call it SFLT1. This SFLT1 is secreted particularly intensely in situations like preeclampsia and also in multiple gestations, like twins or triplets.
Okay, and what does SFLT1 do?
Its main job, essentially, is to act as a decoy receptor. It floats around and mops up another critical factor called vascular endothelial growth factor, or VEGF. Now, VEGF is a really important protective hormone. Its job is to keep blood vessels healthy, promote their growth, and maintain their integrity.
So if SFLT1 is acting as a decoy receptor for VEGF, it must be neutralizing the protective effects of VEGF.
That's exactly right. When SLT1 levels spike dramatically, as they do in preeclampsia or late pregnancy generally, it binds up all the available VEGF. It effectively starves the cardiovascular system, including the heart's microvasculature, of this crucial protective factor. And the result of this VEGF depletion is something called cardiovascular rarefaction.
Rarefaction. Sounds like things are becoming thinner or less dense.
That's a good way to put it. Imagine the heart muscle as like a bustling city, and the tiny capillaries that feed oxygen and nutrients to every single muscle cell are like the intricate network of small side roads. Rarefaction means those crucial side roads are systematically shutting down, withering away, becoming less dense. This puts tremendous stress on the heart muscle, the myocardium, because it's chronically lacking sufficient oxygen and nutrients.
Wow. And this link is absolutely crucial, isn't it? Because it provides a direct physiological mechanism for that epidemiological connection we saw earlier.
Yeah.
PPCM and preeclampsia are often found together because they might share this common pathway triggered by excessive SFLT1, essentially damaging the heart's microcirculation.
Precisely. It ties it all together beautifully. And researchers are learning about other hormonal factors, too, that likely contribute. For example, another placental hormone called activin A seems to correlate with lingering cardiac dysfunction, even a year after delivery. There's also evidence suggesting that high levels of progesterone in late gestation might suppress the heart's ability to efficiently burn carbohydrates for energy, potentially making it more vulnerable when faced with stress. And conversely, levels of vasculoprotective hormones, like relaxin-2, are often found to be reduced in women who develop PPCM.
So it's a complex hormonal storm hitting the heart.
It really is. All these different hormonal threads seem to weave together into this powerful vasculohormonal narrative, explaining why the heart might fail specifically in this peripartum window. But, and this is critical to connect back to the bigger picture we have to reiterate, that these profound hormonal changes only seem to trigger full-blown disease in susceptible women.
Right. Not every woman with high SFLT1 or prolactin gets PPCM.
Exactly. And this is where that genetic susceptibility comes in. It seems to bridge the gap between PPCM and other forms of heart muscle disease, specifically non-ischemic dilated cardiomyopathy, or DCM.
So the idea is the hormonal changes are maybe the trigger or the second hit, but genetics loads the gun, so to speak, predisposes the heart.
That's a good analogy. Research shows that approximately 15%, about 1 in 7 women with PPCM, carry specific genetic variants that are already known to be associated with DCM in the general population. This strongly suggests that PPCM and DCM might lie on a clinical and molecular spectrum. They're related conditions.
And are there specific genes involved?
Yes. About 2/3 of these identified variants are found in a gene called TTN. This gene codes for a massive protein called titin. Titin is actually the largest known protein in the human body. It provides the essential structural scaffolding and elasticity for muscle contraction within the sarcomere, the heart's contractile unit.
Okay, so if there's a fault in this master scaffolding protein, titin, it means the entire heart muscle structure might be inherently weaker, less resilient, and therefore more likely to fail or collapse when hit by that specific hormonal stress cocktail of prolactin fragments and high SFLT1.
That appears to be the vulnerability, yes. However, and this is really important for understanding the model, it's vital to note that the penetrance of these TTN variants is generally quite low, often less than 5%.
Penetrance meaning the likelihood that someone with the gene variant will actually develop the disease.
Correct. Low penetrance means most people carrying these variants don't get sick. This is the clincher for the two-hit or multifactorial model of PPCM. The genetic predisposition, like a faulty titin gene, seems necessary in many cases, but it's almost never sufficient on its own to cause PPCM. You need that specific environmental stressor, the unique peripartum hormonal shift, to actually push the vulnerable heart over the edge into failure.
Got it. So genetics primes the heart, hormones pull the trigger.
That's the current thinking. And identifying these specific genetic variants isn't just academic. It can have immediate clinical relevance for the patient's ongoing care and future risk assessment.
How so?
Well, for instance, identifying variants in certain other genes, like FLNC, which codes for filament C, or DSP, coding for desmoplakin, is particularly important. Because in the general DCM population, these specific variants are known to be strongly linked to an increased risk of developing life-threatening ventricular arrhythmias, dangerous heart rhythms.
Ah, so knowing a patient has one of those variants might mean they need much closer electrical monitoring, perhaps even long after their heart function seems to have recovered on echo.
Exactly. It could influence decisions about follow-up frequency, the need for prolonged monitoring, or even considerations for implantable devices down the line. It adds another layer to personalized risk stratification.
Okay, let's shift gears now to treatment. You mentioned earlier that a key challenge here is the lack of specific, large-scale clinical trials focused just on PPCM. So, current management is therefore largely borrowed or extrapolated from the general guidelines for other types of non-ischemic dilated cardiomyopathy. Is that right?
That's correct. That extrapolation is necessary because we don't have enough PPCM-specific randomized trial data yet, but it definitely highlights some gaps in our knowledge and areas where PPCM might need unique approaches. That said, the standard heart failure treatment protocols do apply. Diuretics like furosemide and sometimes nitrates are used carefully to control volume overload and reduce fluid congestion, easing symptoms like shortness of breath.
But you have to be careful with those during pregnancy itself, I imagine.
Very careful, yes. Dosage needs careful adjustment during pregnancy to avoid causing significant drops in maternal blood pressure, which could compromise blood flow to the fetus. Beta blockers, drugs like metoprolol or carvedilol, are a cornerstone of heart failure treatment. They slow the heart rate and reduce its workload. They are routinely indicated for PPCM, and importantly, they are generally considered safe to use during pregnancy.
Okay. And what about the really powerful neurohormonal blockers, the ones that are known to actually help remodel the failing heart muscle over time, like ACE inhibitors?
Right. Those require a specific timing strategy because of pregnancy. The main neurohormonal blockers, drugs like ACE inhibitors, PG lisinopril, and angiotensin receptor blockers, or ARBs, example losartan, are incredibly effective for heart failure. However, they are absolutely contraindicated during pregnancy. They pose a known, significant risk of harm to the developing fetus.
So they can only be started after the baby is delivered.
Correct. They are typically initiated immediately after delivery. Similarly, some of the newer, highly effective heart failure agents are also being used more and more postpartum for PPCM, again based on extrapolation from their success in other heart failure populations. This includes drugs like sacubitril/valsartan, Entresto, and the SGLT2 inhibitors, like dapagliflozin or empagliflozin.
But there's a caveat with those newer ones regarding breastfeeding.
Yes, the main caveat there is that the safety data regarding their excretion into breast milk and potential effects on the nursing infant are still quite limited. So their use requires careful discussion between the clinician and the mother about potential risks and benefits.
Okay. Now let's focus on the management aspects that seem entirely unique to this peripartum patient population. You mentioned the risk of blood clots earlier.
Yes, the thromboembolic risk is significantly elevated in PPCM, and it's a major concern. Pregnancy itself is naturally a hypercoagulable state. The blood is stickier, more prone to clotting. It's thought to be a biological safety mechanism to prevent excessive bleeding during delivery. PPCM adds another layer of risk on top of that. When the left ventricle, the main pumping chamber, is weak and dilated, blood can stagnate inside it, making it much easier for clots to form. These clots can then break off and travel to the brain, causing a stroke, or to the lungs or limbs.
And this happens often.
The reported rates vary, but estimates suggest clots occur in maybe 5% to as high as 20% of PPCM cases. Because the risk is substantial and the consequences severe, the clinical standard is to maintain a very low threshold for initiating anticoagulation therapy blood thinners.
Especially if the heart function is very poor.
Exactly. Anticoagulation is strongly recommended, particularly if the LVEF drops below about 30 to 35%, or if the patient develops other risk factors like atrial fibrillation, which is an irregular heart rhythm that also increases clot risk.
And thinking about arrhythmias, you mentioned earlier that since the heart function in PPCM often does recover over time, there's a unique approach to managing the risk of dangerous electrical instability.
That's right. While life-threatening ventricular arrhythmias can certainly occur in the acute phase of PPCM, physicians often try to avoid immediately implanting a permanent implantable cardioverter defibrillator, or ICD.
Which is the device that can shock the heart back into rhythm if needed.
Correct. Because there's a reasonable chance the patient's cardiac function will recover significantly, potentially removing the long-term need for an ICD, doctors frequently opt for a temporary solution first. This often involves prescribing a wearable external defibrillator vest. The patient wears this vest, and it continuously monitors their heart rhythm and can deliver a shock if a dangerous arrhythmia occurs.
So it provides protection during that high-risk recovery period without committing to a permanent surgical implant right away.
Precisely. It preserves the option to avoid a permanent device later if the heart function improves sufficiently.
Okay, and what about the delivery itself? Managing labor and delivery for a patient who might be in acute heart failure must be incredibly complex logistically.
It definitely requires meticulous planning and, absolutely crucially, a multidisciplinary team approach. You need maternal fetal medicine specialists, obstetric anesthesiology, and cardiology all working closely together, often in an intensive care setting. The primary goal is always to maintain hemodynamic stability for both the mother and the baby. For patients who are relatively stable from a cardiac perspective, a vaginal delivery is often preferred, as it may involve less physiological stress than a C-section. However, any sign of instability, worsening heart failure, dropping blood pressure, or arrhythmias necessitates a highly coordinated, intensive approach, potentially involving invasive monitoring of heart pressures and specialized critical care protocols during and immediately after delivery.
This brings us neatly to probably the biggest therapeutic question that is truly unique to PPCM, the bromocriptine question. Given that compelling evidence we discussed about the toxic 16-kilodeo prolactin fragment being a key driver, well, suppressing prolactin production with a drug like bromocriptine seems like a direct hit on the disease mechanism itself.
It really is the ultimate example of rational drug design for PPCM, based on our understanding of the pathophysiology. Bromocriptine is a dopamine agonist that effectively suppresses prolactin secretion for the pituitary gland, and it is currently the leading investigative disease-specific therapy for PPCM.
So is it being used routinely yet?
Well, the consensus is still evolving. The European Society of Cardiology, in their guidelines, has tentatively suggested considering bromocriptine, particularly for patients presenting with very severe heart dysfunction, say an LVEF below 35%. However, the general clinical consensus, especially in the U.S., is still mixed. And that's primarily because the clinical trial data we have so far have been somewhat inconclusive regarding its definitive clinical benefit. Some smaller studies showed promise, others were less clear.
So we're basically still waiting for that definitive, large-scale evidence that would justify its routine use for everyone with PPCM.
Exactly. And the trial that everyone is eagerly awaiting, the one that should hopefully provide this definitive evidence, is called the REBIRTH trial. REBIRTH stands for Randomized Evaluation of Bromocriptine in Myocardial Recovery Therapy for Peripartum Cardiomyopathy. It's a large, critical study involving about 200 women being conducted internationally. It's anticipated to be completed around 2026, and its results will likely be pivotal in resolving the ongoing debate over bromocriptine's true role in treating PPCM.
And this whole investigation into suppressing prolactin, it forces us to confront a really significant ethical tension, doesn't it? Especially surrounding breastfeeding. The potential theoretical benefit of suppressing prolactin for the mother's heart, either using bromocriptine or by advising cessation of breastfeeding, has to be weighed very carefully against the undisputed significant benefits of breastfeeding for both the mother and especially the child.
That tension is immense, yes, and is particularly acute in a global health context. The source article explicitly highlights that withholding breastfeeding, even temporarily, is known to increase infant mortality substantially by a factor of more than 10 in many parts of the world where access to safe formula and clean water is limited.
So it's a huge potential risk to the infant.
It is. Therefore, any decision to suppress prolactin, whether pharmacologically with bromocriptine or by stopping breastfeeding, must be made with a clear understanding of this trade-off. While it might benefit the mother's heart recovery, and we're still waiting for definitive proof on that, it can introduce serious risks to the child's health and survival. It forces clinicians and mothers into this difficult position of balancing two absolutely critical health priorities.
So what's the current general recommendation regarding breastfeeding for women recovering from PPCM?
Based on the current, albeit limited, evidence, breastfeeding itself is generally considered safe for the recovering mother, provided she is hemodynamically stable. It doesn't seem to worsen outcomes in most cases studied so far. This means that the default recommendations from organizations like the WHO and the American Academy of Pediatrics still emphasize initiating and continuing breastfeeding unless there is a clear, overwhelming medical indication specific to that individual mother or baby suggesting otherwise. The benefits of breastfeeding are just too profound to withhold it lightly. So despite all the rapid advances we've seen in understanding the why of PPCM, the pathogenesis major areas of uncertainty still persist. and these create real dilemmas for patients and the clinicians caring for them. The first big one, and often the most emotionally charged question, is the risk of recurrence in subsequent pregnancies.
Right. Counseling a young woman who has survived PPCM but understandably wishes to expand her family further must be incredibly difficult when that future risk is so uncertain. What do we actually know about the parameters for recurrence?
What we know is that the risk is wide-ranging and, frankly, alarming. The data suggests the disease recurs in anywhere from 10% up to 50% of subsequent pregnancies.
10 to 50%. That's a huge range, and even the lower end is a significant risk.
It is. And furthermore, when PPCM does recur, it often carries outcomes that are significantly worse than the initial episode, including higher rates of persistent dysfunction and even higher mortality rates. Clinicians have desperately searched for reliable predictors, ways to tell a woman definitively what her specific risk would be. But unfortunately, those strong predictors remain elusive. While intuitively you'd think that a lack of complete systolic function recovery before the next pregnancy would be the strongest predictor of a bad outcome, and it is associated with worse outcomes, it's actually not a very strong or reliable predictor on its own. Some women with incomplete recovery do okay, and some with full recovery still recur.
So there's just a lot of uncertainty there.
A tremendous amount. Because of this uncertainty, the standard advice is necessarily cautious. Any subsequent pregnancy after PPCM is considered very high risk and demands the absolute highest level of careful, multidisciplinary monitoring, starting from the earliest stages of pregnancy or even preconception counseling to maximize the chance of a positive outcome for both mother and child.
And thinking about the long term for these survivors, PPCM patients are often young women, potentially facing a lifetime of chronic heart issues or at least the fear of recurrence. You mentioned earlier that long-term outcomes, especially looking out beyond 5 years or so, are severely understudied.
That's a major gap in the research landscape, absolutely, especially given the young age of the affected population. These women have decades of life ahead of them, and what limited long-term data we do have reveal a substantial and often unrecognized mental health burden associated with surviving PPCM.
That makes sense. Dealing with sudden, life-threatening heart failure right around the time of childbirth, which is already a physically and emotionally vulnerable time, must take a massive psychological toll.
It really does. Studies indicate that as many as half of women with a history of PPCM may meet the clinical criteria for significant mental health disorders, including severe depression or post-traumatic stress disorder, PTSD.
Half of them. That's staggering.
It is, and it underscores that comprehensive treatment for PPCM must extend far beyond just managing the cardiovascular aspects. It absolutely has to include robust screening for and access to mental health support services.
Okay, let's turn to a really practical but high-stakes clinical question for those women who do appear to recover their heart function. The uncertainty surrounding when or even if they can safely stop their medications. If the echocardiogram looks good, the LVEF is back above 50%, when can a patient safely come off that lifetime regimen of powerful heart failure drugs like beta blockers or AC inhibitors?
This is honestly one of the most fraught decisions in long-term PPCM management. Because while the standard echocardiogram might show functional recovery at rest, the LVEF looks normal, this doesn't always guarantee complete cellular recovery. For instance, if you challenge the heart, put it under stress using exercise testing or maybe a dobutamine stress echocardiogram, you can often unmask persistent subclinical dysfunction. The heart still doesn't respond normally under load.
So the resting snapshot looks fine, but under the slightest strain, that underlying vulnerability reappears.
Precisely. It suggests the recovery might not be truly complete at the cellular or metabolic level, even if the resting pump function seems restored. And we know from experience in similar conditions, like other forms of recovered dilated cardiomyopathy, that premature withdrawal of neurohormonal blocking medications is associated with a significant risk of disease recurrence or relapse.
So stopping the meds might let the underlying problem resurface.
That's the concern. And because specific, large randomized trials looking at medication withdrawal specifically in PPCM are currently lacking, the recommended approach is, again, highly cautious. A reasonable, though admittedly uncertain strategy that many experts follow is to wait at least a full year after documented echocardiographic recovery, LVEF consistently 50%. Then, if withdrawal is considered, to do it very slowly, withdrawing only one medication at a time, perhaps over several months. And crucially, maintaining very close long-term clinical and echocardiographic monitoring indefinitely, even after stopping meds, to catch any signs of relapse early. It's about minimizing the risk of the heart failure returning.
Okay. And
Yeah.
this finally loops us right back to that overwhelming issue we started with way back in section 1, the urgent need to address the profound inequity we see in PPCM. We established that Black women in the U.S. are 4 times more likely to get PPCM and have radically poorer recovery rates and higher mortality. If the fundamental cause is molecular, these hormones, these genes, why is the outcome so starkly stratified by race and geography?
The data we have strongly suggest that the primary drivers of these poor outcomes, these disparities, are overwhelmingly systemic, not biological. Studies looking at this have indicated that socioeconomic factors, particularly using metrics like neighborhood deprivation indices, which capture access to resources, healthy food, safe environments, chronic stress levels, and also factors related to healthcare access and potentially provider bias. These are likely the dominant forces driving the inequities we observe.
More so than differences in genetics between populations.
It appears so, yes. While genetic predisposition plays a role in susceptibility, the available evidence suggests it doesn't explain the vast differences in outcomes between racial groups in the U.S. or between developed and developing nations. The differences in survival and recovery point more towards disparities in timely diagnosis, access to specialized care, adherence to treatment, and management of comorbidities, factors heavily influenced by social determinants of health and systemic inequities within the healthcare system.
So this implies that perhaps the greatest immediate impact we could have on reducing PPCM mortality might actually come from improving screening protocols, ensuring equitable access to care, and addressing bias. Maybe even more so than waiting for the definitive results of, say, the bromocriptine trial.
That's certainly the emerging consensus and a major takeaway from the review. The source explicitly emphasizes that wider, more systematic use of simple diagnostic biomarkers, like the plasma BNP test we discussed, could be crucial. BNP testing can be easily administered in community settings, emergency rooms, primary care offices. Implementing it more broadly, especially for peripartum women presenting with concerning symptoms, could be key in reducing those critical diagnostic delays.
Especially for patients who might not have immediate, easy access to specialized cardiology expertise or echocardiography.
Exactly. Getting that early diagnosis, prompting the right follow-up, regardless of a patient's geographic location or racial background, that seems to be the most immediate, actionable priority for saving lives and reducing the devastating disparities we see with PPCM right now.
Well, this deep dive has truly illuminated the sheer complexity of peripartum cardiomyopathy. It's clearly a devastating condition. You have this convergence point where a patient's unique genetic susceptibility meets the profound specific hormonal changes of late gestation and the postpartum period. And this collision creates a medical crisis that demands aggressive, highly tailored treatment and obviously much more urgent research.
Absolutely. We've established, I think, a pretty detailed understanding of the disorder now. It's defined by that acute systolic dysfunction occurring around childbirth. It seems driven by specific vascular hormonal triggers, that toxic 16-kiloday prolactin fragment, the anti-VEGF action of SFLT1 from the placenta, and it's often compounded by an underlying genetic predisposition, perhaps involving genes like TTN.
But the core takeaway, the challenge that really lingers after reviewing all this, is that stark, unavoidable disparity. We've established the pathogenesis seems tied to these precise molecular shifts, these genetic factors. Yet, overwhelmingly, it appears socioeconomic factors, delays in diagnosis, and systemic inequities are the leading drivers of who has poor outcomes, who recovers, and ultimately who survives PPCM, both in the U.S. and globally.
Which leads us to our final provocative thought for you, the listener, to consider.
Ugh.
We now understand that the molecular mechanism, the prolactin, the SFLT1, is critical for developing PPCM. But it seems the systemic mechanisms, things like socioeconomic status, access to care, diagnostic delay, are critical for surviving it. So the question becomes, how can medical research, healthcare policy, and society at large, how can we simultaneously pursue both? How do we fund the crucial work needed to unravel the remaining molecular mysteries and, at the same time, implement the necessary clinical and public health reforms to aggressively tackle the systemic inequities that currently seem to govern life and death from PPCM?
Thank you for watching The Funnel Effect.